Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Rebecca Kristeleit from Guy's and St. Thomas NHS Foundation Trust and Comprehensive Cancer Center, King's College, London. We're going to be talking today about a recent publication in JAMA Oncology titled Pembrolizumab in Patients with Advanced Clear Cell Gynecological Cancer, a phase 2 non-randomized clinical trial. So, Rebecca, thank you so much for accepting our invitation. Welcome to the podcast. We're really excited to discuss this manuscript with you. And of course, obviously, a very important topic that often comes up in discussion when we're trying to evaluate and manage patients with clear cell carcinoma. So thank you again for accepting our invitation.
Thank you, Pedro. It's a real pleasure to be here, and I'm looking forward to discussion and seeing what questions people have.
Excellent. So I wanted to start by just if you can tell us about clear cell tumors of the gynecological tract and why treat them as a single histopathologic entity.
Yeah, so these are a rarer type of epithelial cancer that we have across all subsets of gynecological cancer, most commonly in ovary, and then followed by endometrial. In ovary, it's around 10 to 15% of our epithelial ovarian cancers. So rare, but not so vanishingly rare. So everyone who treats gynae cancer will come across these patients. And we know they've got a very distinctive histological appearance. We know that they histologically are derived from endometrial type cells, and many clear cell cancers begin in endometriotic cysts or with a history of endometriosis. And I think this is an area of real interest, and it's important for us to understand that more as oncologists and gynecologists. So the reason we think that they're a distinct entity is that clear cell cancers occur in other organ types, such as renal, very commonly. And we have data, molecular data, that shows there is a lot of similarity in the molecular profiles, whether these cancers are derived from the gynecological tract, particularly ovary, or renal tract. And we know that in both groups that they tend to respond poorly to chemotherapy, and that in renal cell, they're also quite responsive to anti-angiogenics and immunotherapies. So there is molecular evidence that they're similar. There's histological evidence that they're similar, so looking at the cells under the microscope. And then there's clinical indications that they're similar in the fact that they're quite, they tend to be less responsive to standard of care chemotherapy and more responsive to immunotherapy, as we're beginning to see in gynae. So for all those reasons, that's why we think of them as a single entity.
Well, excellent. Thank you for that introduction. Now I was wondering if you can speak a little bit about the immune microenvironment of these tumors. Why are they a good target for immune checkpoint inhibitors?
Well, we really started this study because there had been a few ad hoc published case reports, really, either within clinical trials and as case reports, of patients with clear cell ovarian cancer responding to immunotherapy. And it was one here, one there, so it was never big numbers. So we thought that was an interesting signal. And then we understood more about the molecular environment. And as there's still very little data actually on what the clear cell tumor microenvironment looks like and what makes it specific to benefiting from an immunotherapy approach. And we do think that it's very much the tumor immune microenvironment that is relevant here in clear cells. So you're going to miss potential sensitivity signals if you're just looking at PD-L1 or even MMR deficiency in clear cell, because it's much more what is the spatial arrangement of the immune cells in the environment, what's the inflammatory type signal that's going on there, and which cells are close to others, and what's the quantity, for example, or percentage of CD8 T cells compared to other type of T cells. So it's likely to be really, really detailed and dependent on the spatial topography of the tumor immune microenvironment, and also what's in the tumor immune microenvironment. So I think the usual markers that we might think are indicative, for example, in cervical cancer, PD-L1 to some degree, and MMR deficiency and endometrial cancer, these are not really showing the same ability to predict benefit to immunotherapy in clear cell cancers.
Excellent. So now let's talk about this trial, also known as the PEACOCC trial. Tell us a little bit about the study design and the patient population that was evaluated and the endpoints of the study.
Yeah, so the study was designed as a single-arm study. So it was signal seeking, really, because before this study was conceived, there was actually no published data and no clinical trial that had been dedicated to looking at clear cell cancers as an entity with immunotherapy single agent. And it's only since then that we've really had quite a flurry of really interesting studies that have given us more data in this area. So this is why we did it as a sort of a group of ovarian, endometrial, and cervix, as we've said, because of the similarities, but also because we wanted to optimize the numbers of patients. And everyone was telling us, oh, it'll be so difficult, there won't be enough of them, they'll be too sick, they won't be biopsiable. And we didn't think that would be the case. So we thought, we'll just get on and do this study. And one of our main motivations, other than signal seeking from the immunotherapy itself, was to really drill down on the molecular markers and getting a good library of translational samples to properly question what was going on, because we could see there was a massive paucity of data in that respect, and there really still is to some degree. So this is why it's single arm, because we wanted to maximize the number of patients that are having the treatment. And because there was so little data around, we wanted to also, for that reason, maximize the number of patients that were getting the treatment, so we could understand whether it was any good or not. And it's an academic study, so financing is always limited to that for those patients. And we also felt that chemotherapy was a complete waste of time. So we didn't want to spend our precious efforts based on in relapse disease, published data of around 0 to 8% for benefit from chemotherapy. So we felt that's something that could be done later. So we focused our efforts into signal seeking, into gathering translational research samples. This was a biopsy mandated study, so all patients in the study had baseline biopsies done at the time of entry to trial. And we've got multiple longitudinal samples. So for all those reasons, that's why our endpoint, we sort of toyed with this. Should we look at overall response rate, or should we look at something that's a little bit different? And because response rates are important to some degree with immunotherapy, PFS is important to some degree, but probably what's emerging is that overall survival might be the thing that is affected most. So they kind of stay in this limbo where we're discovering some of these patients. They have their immune therapy, they don't necessarily shrivel away the cancer, but everything just kind of freezes for a while and stabilizes. So the endpoint we settled on was progression-free survival, but having that defined as a particular 12-week rate, so what we call a PFS rate, which means that you fix your point at which you're going to look for PFS before you do your trial. So we were looking at 12 weeks. What's the rate of patients that does not have progression at 12 weeks? Because we hypothesize, and based on data, that actually the majority of patients, if they were having chemotherapy, would be showing signs of progression at that time. So we thought that was a good interval, but we did do a 6-week scan as well because we wanted to catch things early, because we knew there'd probably be some early progressors. So we did 6-week and 12-week scan. Our primary endpoint was progression-free survival at 12 weeks. And we thought around 15% of patients, if they were treated with chemotherapy, would be progression-free. And in fact, with the immunotherapy, we found that 42% were progression-free. So we felt that this was a really strong. So that was it. That was it over the fence, as it were, for hitting the primary endpoint. We just had to get more than 15% that were progression free, and 42% was a nice number. And then obviously we had secondary endpoints that were looking at overall response rate, overall survival, and median progression-free survival. And actually our median progression-free survival was slightly less than the PFS rate of 12 weeks of 42%. So median was 2.7 months. And we wouldn't have picked that up necessarily if we hadn't done those two, the early scan at 6 weeks. So the response rate as a secondary endpoint was an important one because it showed us that we had 25% of patients with a confirmed partial response. And the duration of response is a thing that stands out from this study. So 25% is still, we can do better, and we know we can do better now with other approaches by adding in bevacizumab to immunotherapy or giving 2 immunotherapy agents, although that's quite toxic. So, this is a benchmark for those other studies to understand the contributory factor of Bev, of a second IO agent. So I think this is really quite a nice study to be that benchmark and to say, look, this is what we can achieve. It's definitely, I'm saying definitely, probably highly likely to be better than chemotherapy if it had been a randomized study. And that we're probably already making headway with adding in the second agents that we're choosing. So that's why we designed it the way we did. The endpoints, we thought we wanted to describe the patient experience, not just focusing on PFS, but we needed the response rate. We wanted the overall survival, which is also looking quite good. So it was just collecting as much data as possible. And the other thing that we've collected, and we're looking at generating another paper, another manuscript, and describing what happens to these patients after they've finished immunotherapy. So do they do better with subsequent chemotherapies, some of them, because many of these patients are still alive, minority, but they are. So it's all really interesting.
Great. So, and I just want to mention kudos to you for proceeding and being persistent in pursuing the study, even in the face of the dampened enthusiasm by some. So congratulations.
No, thank you. And it's nice. I mean, we always knew in our hearts we could do that because we know that patients are really very committed, and particularly patients with rare diagnoses. They don't want to hear that they're rare. They don't want to hear that you've not got trials. They don't want to hear that you don't know what to do or you don't have data. They just want something that works. So, they're committed.
Excellent. So now let's get on to the highlights, the results. What did you find? What should the audience take away as really the highlights of the study?
So I think the highlights are, this is tolerable treatment, that patients' survival, the median overall survival for these patients, remembering that they have a median prior lines of treatment of 3. They've already have 3 lines of treatment, okay? And in this, after that median, their median overall survival is around a year, okay? So this is, to me, that is a massively important signal that something is changing this dynamic where we would normally expect these patients to have a life expectancy, honestly, of around 3 months. That they are living a median of around a year, just under. And that although the other thing that I found slightly surprising is that that's despite a median PFS of just under 3 months, So you're not seeing this huge a really dramatic response, but I think this survival comes from a stabilization. So the PRs and the SDs are really important markers, not just the PRs. You need to look at both. And stabilization of disease is a really important benefit of this treatment. So I think it's those two things. The overall survival is really surprising in a heavily pretreated population of patients with, according to literature, survival of around 3 months on average normally with chemo, and that they're tolerating it and they're going on to have other treatments, So those were my main takeaways.
Excellent. So, Rebecca, now we go to the questions from our fellows in the journal, and I'm going to go to a question by Helena Obermeyer from Sydney, Australia. And she's asking, was there any difference in response between ovarian clear cell cancers and those arising from other gynecological sites, such as endometrial or cervical?
Yeah, I like this question because it comes up a lot. And I think it's another question that kind of highlights the fact that this is a morphologically, it's the morphology of the cancer and the diagnosis that's important here, not the organ of origin. So within the PEACOCC trial, we had 41 of the 48 patients had ovarian clear cell, and 7 had endometrial or cervix, 1 cervix, 6 endometrial. Now, obviously tiny numbers, but we have looked at the response rate in ovary versus endometrial and cervix, and they're similar. So we said 25% for the overall population. Sorry, don't have the numbers for ovary on their own, but 25% for the overall population, and very similar for the 7 patients with endometrial and cervix, which was 28%. So it, on a par. So it doesn't seem that there's any standout difference here. And that's consistent with what we're seeing from the cohort of clear cell MMR peaks. Remember, that was another highlight actually from this study, is the fact that virtually all the patients are MMR proficient. So people say to you, oh, well, around 15% of clear cell ovarians are MMR deficient. Well, not in our study, only 1. So that's a really important takeaway as well. So and that tells us that there's other stuff going on we need to look at molecularly. So going back to the endometrial clear cell story, Pembrolizumab, as we know, has been approved in recurrent endometrial cancer. We've looked at MMR proficient and deficient patients. Now, if you look at the MMR proficient group of clear cell patients, so very similar to the clear cell patients in PEACOCC, their response rate to Pembrolizumab is actually not very different from the one we're seeing in this study. So it's similar. So I think it's consistent that this is a clear cell phenomenon and not relying on endometrial or ovarian or cervical origin.
Excellent. Next question comes from Frederica Strosch in Heidelberg in Germany. How many participants in the trial had pure clear cell histology versus mixed histology? Did you observe any difference in treatment outcomes between these subgroups?
So this is, again, a very relevant question and a very on the point question. We stipulated in this study, because again, we knew from previous studies and we know from our histopathologists that diagnosing clear cell is not always straightforward, and that if you start looking at all the patients that are supposedly have clear cell cancer, actually many of them don't. So we stipulated as part of the screening process that all patients had to be diagnosed by a specialist gynae histopathologist. And in addition to that, they had to have at least 50% of the tumor cells had to be clear cell. So 50% or more was what we defined as clear cell morphology for this trial. Those who had pure clear cell versus those who were more mixed, 50 to 99%, I guess, if you want to be pedantic about it, I don't know.
Okay.
But that's something that we can look at. So we don't have that in the primary data of the study, but we do have that data because we know the histopathologists have recorded that. So I don't know the answer to the precise question, but I can tell you that we've looked very carefully at the histopathology.
Very well. So this next question goes from Luisa Prope in University Hospital Münster, Germany. And she asks, in daily clinical practice, we typically schedule restaging every 3 months, meaning that a median progression-free survival 2.7 months would typically not be detected. How do you interpret this finding, and what does it say about pembrolizumab's use in this patient population?
Yeah, so I think because we had our PFS rate as the primary endpoint at 12 weeks, we wanted to be understanding what was happening early on. And we knew that historically patients were likely to have died or progressed at 3 months. So we wanted to have the trajectory for those patients. So we were very careful about documenting our 6-week and our 12-week scan. And then if patients had a response or had progression, then we needed to confirm that. So the patients wouldn't necessarily come off at 6 weeks. They would continue treatment until we had confirmation of progression. So that's why we designed it that way. I agree that 3 months is the standard timeline. We do find, though, with advanced clear cell cancers who have had several lines of prior therapy, that you often need to do a scan earlier because they're symptomatic. And CA125 monitoring is not nearly as robust in clear cells, so some of them just don't secrete it. So I think it doesn't have any implication for the use of pembrolizumab because you'll do what is clinically needed. And I don't think you have to do that 6-week scan. That was just to make sure we had very clear documentation of the trajectory through to the primary endpoint. So I don't think it has implications for a standard of care or for the use of immunotherapy in the clear cell setting.
Yeah. And you did mention prior treatment. So this next question is from Rim Abu Chakra in Lebanon. And she asked 40% of patients in the study had received previous anti-angiogenic treatment. Did this impact pembrolizumab activity?
Actually, it didn't. So we thought it was really interesting that many of the patients, quite a large proportion, had had prior anti-angiogenic treatment. The reason we wanted to know that is because we know that's a very effective treatment for clear cell cancer. So we know that the patient has been optimized in some way. You know, they've been fit enough for it and they've been optimized. When we looked at the 13 patients that had had prior anti-angiogenic treatment in this study, we found that they had a response rate of around 23% to pembrolizumab. So again, totally consistent with the response rate of 25% for the whole population. So there did not seem to be an advantage in having had prior anti-angiogenic treatment, except they may have have had a longer preamble to get to the study.
Yeah. So now a question about biomarkers. Helena Obermeyer from Sydney, Australia. She's asking, your study found that biomarkers like MMR deficiency, ARID1A, P53 status, PD1, PDL1 expression didn't clearly predict response to pembrolizumab. Why do you think this was the case? And do you think there are other ways we could identify a subgroup of clear cell cancers that would be most likely to benefit?
Yeah, so the reason I think those biomarkers haven't predicted benefit is because we're measuring the wrong thing. So these are not the drivers of immune sensitivity in this group of patients, as we might expect. Now, TMB, we have not published TMB data yet, but we're sort of in the process of doing the main TR work. This is just some IHC that was published in the primary paper. So TMB, I think, is something that is really important to look at in this group of patients. And I think it comes back to one of my earlier comments that really the key here is the tumor immune microenvironment. It's the spatial architecture and it is the distribution of the immune cells across the microenvironment that's key here.
As
And
a
we,
follow-up. Yeah,
sorry.
I'm sorry. Go ahead.
I was just going to say that I think, and this is what we still don't understand. So lots of people have done, or several groups have done some really lovely work on on genetics and looking at the genetic profile. And that does classify clear cells maybe into immune groups and anti-angiogenic groups and maybe inflammatory groups. But when you're looking at the genetics, you're still missing the spatial topography. And I think this is the bit that's really driving what goes on. And if we look at other tumor types like melanoma, they're beginning to look at the microbiome. You know, it might even not be the tumor itself, it might be the environment it's in. But I believe that a lot of what we're going to see and what is beginning to emerge with the small volume of data we have is it looks like the pattern and type of T cells might be important in determining response and how they interact with each other.
Interesting. So, as a follow-up to the topic of biomarkers, I'm going to go to a question by Sofia Bigardi um, in Italy. And she says, in the PEACOCC, PD-L1 expression didn't clearly correlate with benefit. What do these findings suggest about the underlying biology driving response to PD-1 inhibition in clear cell gynecologic cancers? How might they shape the search for more reliable predictive biomarkers in such a rare tumor?
So what was the one? Sorry, I missed the very beginning of that question. Was it PD-L1? Why did
Yeah,
PD-L1 not correlate?
that's
Well,
right.
I mean, I think PD-L1, I don't think is a brilliant biomarker for immunotherapy in gynae. I know we use it in cervix and it's less than or plus, CPS1, but if you look at the data from which that's derived, it's not a very strong cutoff. I think probably if it's really high, that might be an indicator. But here we've just got 15, we've got a smallish, about 40 patients, I think, that had tissue suitable for PD-L1. And I just don't think it's the right marker. It might be PD-L2 that's important. We did publish some data on that, looking at PD-L1 and PD-L2, and that they might both be relevant. So I just think it's the wrong biomarker. It's too generic. It's not telling you about those spatial interactions. It's just telling you there might be some immune activity. It's just not specific enough. So I don't think that's the way forward for clear cell. And that is consistent with others' findings. So that's not just a message from this study.
Excellent. So this question comes from Rossano Marina from Milan, Italy. And she's asking, with emerging data on biomarkers such as TERT promoter mutation, immune gene signatures, tumor infiltrating lymphocytes, and tumor mutational burden, which molecular features would you include in future prospective studies to better identify who might benefit most from immunotherapy in clear cell carcinoma of the ovary?
Well, obviously we need to wait for all the TR to be done, but I think if I had to be pinned down now to say what do I think, it's TMB and TILs. And I think, the genetic immunogenic or angiogenic genetic signatures I think are interesting, and so they can be looked at if possible. What I haven't said so far is that we have set up a randomized phase 2 study for clear cell internationally, and that's being run from South Korea. It's called DOVE, the DOVE study, and that is looking at dostarlimab as the PD-1 inhibitor, dostarlimab in combination with bevacizumab versus dostarlimab versus standard of care chemotherapy. So it's a really nice study to strengthen our understanding of PEACOCC with an immunotherapy single agent arm, standard of care arm, and your IO bevacizumab. And we know from the ANOVA study that IO bevacizumab is about a 40% response rate. We know that as well from Pembrolizumab, the study run by David Tan Lara, it's called, which also showed a similar response rate and a much better progression-free survival than in PEACOCC, so about double. So and Dove has a big plan of translational work attached to it, and translational samples. So we are collecting all those samples from these patients as well. So I think over time we're going to have a lot of information, but as I said, my gut instinct at the moment is that TMB might give us an indication, but specifically it's looking at the spatial relationships in the TME.
That's great. And you mentioned the Dove trial. Is that already accruing or is planned for?
Already accruing. It's
Oh,
already accruing. It's accruing well in Southeast Asia. We're opening in the UK in the next month or two. And there'll be 200 patients, just under 200 patients randomized to that. So we're really excited about that study. We've got over 50% recruitment already. So
great.
clear cell is not that rare.
Exactly, exactly.
Mhm.
No, again, a great effort by a global consortium of investigators. So now moving on to next question, Mariana Carvalho from Sao Paulo in Brazil. She's asking, it is affirmed that you've demonstrated that a trial of a rare histologic subtype of gynecologic cancer is feasible even with mandated translational sample collection, including tumor biopsies, with enrollment occurring over a 30-month span in large part during the COVID-19 pandemic. So, do you think performing a phase 3 trial with this rare entity to validate this finding is feasible? So, of course, obviously, I think that we have answered that with a Dove trial. So, but
Oh, that Dove is phase two,
it's
randomized
phase
phase
2.
two.
Okay.
But
Okay.
interestingly, there is a phase three that's already up and running in China.
Ah, interesting.
Uh-huh. So the answer to her question is yes.
Excellent. Sofia Bigardi from Italy, she's asking, given that advanced clear cell gynecologic cancers lack a universally accepted standard of care in the recurrent post-platinum setting, and that historical outcomes with second-line chemotherapy have been so poor, if a randomized trial of pembrolizumab were to be conducted, what would you consider the most appropriate and clinically relevant control arm?
Well, I suspect that's going to be single agent immunotherapy. And I think you're going to be looking at either IO or IO-Bev or some bispecific T cell engager. So I think what I'm hoping is that Dove will tell us that we don't need to worry about chemotherapy for these patients, or give us a very clear idea of what the contribution is of chemotherapy. And I suspect immunotherapy will be the control, monotherapy will be the control arm that needs to move forward. But we'll see, I might be wrong, but that's what I would predict.
Makes sense. So, Rebecca, we'll ask a question from Natalia Tejeda from Hospital Clinic of Barcelona in Spain. And she's asking, considering the growing body of evidence from trials such as PEACOCC, MOCA, INNOVA, Keynote 775, um, can we begin to favor one immunotherapy regimen over another? Or is further stratification based on tumor molecular profile still necessary to optimize treatment selection?
Interesting question, actually. I think, in PEACOCC, we have one patient who remains in remission. She completed her 2 years of pembrolizumab. She's not even needed re-challenge about 2 years later. So there are, again, this is why translational research embedded into trials is so important, because what we hope we'll find is that in these extreme responders and the ones that are coming off treatment after 6 weeks, that we'll see some differential that will really guide us as to the age-old question of whether an immunotherapy agent on its own, which is much better toxicity management profile compared to maybe combination IO or IO and Bev, which actually isn't bad toxicity wise, is needed. But so I think in answer to the question, we do need more understanding before we can define that clinically. So there's nothing at the moment that can help us. I think the only clinical signal we have at the moment is the response rate and our standard readouts of benefit. And therefore, based on that, on this, the single arm and essentially mainly single arm studies that we have so far, it would suggest that a combination of IO or IO and bevacizumab is superior to immunotherapy alone. But bottom line is, please try and give these patients immunotherapy in some way, ideally within a clinical trial context, because I think that's their best chance at this point in time.
Excellent. So, Rebecca, as a last question, as a new strategy here in the IJGC podcast, we now are incorporating Sign of the Times, and we are going to pose a question that is a question that is formulated by artificial intelligence
Oh yeah.
in its interpretation of your study. So, the question from AI to you about your study is, given that median progression-free survival was only 2.7 months, and the
Uh-huh.
majority of patients progress rapidly despite pembrolizumab,
Yeah,
we at risk of overstating the clinical benefit of this drug in clear
yeah.
cell gynecologic cancers just because a small subset achieved durable responses.
Yeah, so I think AI has a good point there. Okay. I think you can say, you can always turn around this a study result and say, well, yes, okay, 25% response rate, that's great, but that means 75% of patients didn't respond. And that's absolutely right. But as I said from the very beginning, this is a signal-seeking study, and I think it has found a signal. So my answer to AI is you've got to start somewhere, and we have. And we found the signal, and now we're building on it by adding in the second drugs that are really going to improve things. And the other thing we've done, even though we've only got a 25% response rate, is we've got a library of samples that can't be recapitulated, you know? So we can answer questions that other people can't. We can add to the questions others have answers to by giving the answer for the single agent immunotherapy. So it just helps us really understand the incremental benefits of all the drugs. So I would never overstate it. And I have never gone out there and said, oh, we must be treating all our patients with immunotherapy. But since PEACOCC was published, and we've got the data from Innova, we've got the data from Lara, we've got the activity of setting up a randomized phase 2. We've got phase 3 activity in China, and we've got IO activity at 50% response rate. I think we can say now that immunotherapy is definitely an approach you need to prioritize for your patients with clear cell cancer at some point in their pathway, irrespective of platinum sensitivity or resistance.
Well, very well articulated and eloquent answer to our AI provocative question. So, which I thought was pretty good, actually. But
Yeah, it was very good.
Rebecca, it's been so much fun. You have taught us so much. Thank you so much for your courage in pursuing these questions and challenging, you know, the as I said, the dampened enthusiasm for studying rare tumors. Kudos to you. Congratulations to you and the team, and congratulations on such a great publication and moving the field forward.
Thank you very much. It's been a real pleasure.